Well, let's get started. Good evening. I'd like to welcome everyone to tonight's Journal Club meeting. My name is Dr. Mark Troxler. It's my pleasure to serve as the club advisor moderating tonight's Journal Club meeting. Just a little bit briefly about myself. I'm a primary care sports medicine physician. I initially did ER training at Oklahoma State University and then switched to internal medicine with the University of Oklahoma. I did a sports medicine fellowship with Dr. Stephen Rice at Jersey Shore University Medical Center and Dr. Rob Monaco at Rutgers. I've been practicing emergency medicine and sports medicine for the last 25 years. I see a wide variety from youth athletics all the way to professional athletes. I've been on the executive board for sports medicine for USA Track and Field in most of those years. Recently, we've gained the Paralympics. It's now part of USA Track and Field. And we did have our first Paralympic meet this past weekend in Dallas for track and field. And those Paralympic athletes are amazing. And the goal of the AMSSM Journal Club is to provide a national platform for student and resident members to present an article from the list of top 120 articles that every sports medicine fellow should be familiar with. Our intent, of course, is to make this fun learning experience and give medical students and residents mentoring opportunities with other AMSSM members while developing skills of reviewing articles and making PowerPoint presentations. We have two presentations tonight. The format for the Journal Club meeting is that each presenter will have an opportunity for approximately 20 minutes to including a brief question and answer segment after their presentation. If you have questions using the chat function and during the question and answer, I will call on you so you can ask your question to the presenter or I can read it for you. So we'll do the first presenter. It's my pleasure to introduce our first presenter tonight is Dr. and I may not pronounce this right, Ryunosuke Hisatomi. And his club mentor is Dr. John Kiel. Dr. Hisatomi is originally from Tokyo, Japan, and is currently a second-year fellow at Family Medicine Residency at LSU Health in Shreveport. He's been serving as a team physician for the Centenary College of Louisiana. It's NCAA Division III and the Shreveport Mudbugs ice hockey team. He enjoys combining his passion for medicine with his love for sports. He was honored at this recent AMSSM 2025 Resident Scholarship and plans to apply for a sports medicine fellowship in upcoming cycle. He's a devoted NBA fan. He's been running low on sleep lately because of the excitement of the playoffs, and he has a hard time going to bed. His presentation is on our article of Splenic Injuries in Athletes, a review. And I also like to thank Dr. John Kiel for serving as his club mentor. Dr. Kiel is an associate professor of emergency medicine and sports medicine at the University of South Florida, where he holds a core faculty position in emergency medicine residency program and helps with team coverage with the USF Bulls, University of Tampa Spartans, Tampa Bay Buccaneers, and Tampa Bay Lightning. In his free time, he enjoys CrossFit and spending time with his family and his dogs. We'll turn it over to Dr. Hisatomi for his presentation.
All right, let me share my PowerPoint. All right, let's start. Hi everyone, my name is Ryunosuke Hisatomi. Today I will be presenting a review of splenic injuries in athletes based on the article by Gannon and Howard published in Current Sports Medicine Reports in 2010. Let's get started. So in this presentation, we will review mechanism and signs of splenic injury, diagnostic tools, management options, and return to play guidelines. Let's begin with a quick overview. Splenic injuries are not very common in athletes, but when they do happen, they can be life-threatening because the spleen is such a vascular organ. In fact, the spleen is the most commonly injured organ with a blunt abdominal trauma, especially in contact or high-speed sports. That is why we always need to consider splenic injury in any athlete who presents with abdominal pain or discomfort after trauma. The spleen is located in the left upper quadrant of the abdomen, tucked behind ribs 9 through 11. Because of this position, it's well protected by the rib cage, although it can still be injured in blunt trauma. It's enclosed by a fibroelastic capsule. It's highly vascular, receiving about 5 to 6% of the cardiac output. This rich blood supply is why splenic injuries can lead to significant internal bleeding. The spleen has several important functions. First, it filters the blood and removes all red blood cells. It is also important in the immune response by producing lymphocytes and antibodies. In addition, the spleen is involved in hematopoiesis and phagocytosis, where it helps remove pathogens and cellular debris. In children, the chest wall is more flexible, and the splenic capsule is thicker compared to adults. This means the spleen in pediatric patients can tolerate trauma better, as the force is more easily absorbed. Also, the spleen in children has higher elasticity, which helps limit bleeding. As a result, non-operative management tends to be more successful in pediatric patients than in adults. There are several ways athletes can injure their spleen. One is through direct blows, such as tackles in football game or being hit by a lacrosse ball. Another common mechanism is falling onto a hard surface, like during mountain biking or snowboarding. Early signs of splenic injury can be very subtle, and they are often missed during the initial evaluation, especially if the mechanism of trauma seems minor. That's why we have to maintain high index of suspicion in any athlete with abdominal trauma, even if they appear stable at first. It's important to take a detailed history and perform a careful physical examination. When taking the history, there are a few key things to look for. First, ask about mechanism of injury, whether it was a direct blow or a fall. Also check if the patient had any recent upper respiratory infections, especially mononuclear oris, mono, which is known to cause splenomegaly and increase the risk of splenic rupture. Fever or systematic symptoms before the trauma can also raise suspicion for an enlarged spleen. Finally, ask about any hematologic conditions like bleeding disorders or sickle cell disease that might increase the risk of splenic injury. Now let's talk about the clinical signs of splenic injury. One of the most classic findings is tenderness to palpation in the left upper quadrant. And you may also see curd sign, which is a referred pain to the left shoulder. This happens because blood in the abdomen irritates the diaphragm and stimulates the phrenic nerve, which shares nerve roots with the shoulder. Signs of shock like hypotension, cool extremities, and delayed capillary refill can indicate ongoing internal bleeding. Later on, you may see Cullen sign, bruising around the umbilicus, or Gray Turner sign, bruising on the flanks. They are late findings that suggest significant intra-abdominal bleeding, but they usually appear hours after the injury. When evaluating for possible splenic injury, The imaging strategies depends on the patient's hemodynamic status. For unstable patients, we don't wait for imaging. These patients should go straight to the OR for an exploratory laparotomy for diagnosis and treatment. For stable patients, the best imaging modality is a contrast-enhanced CT scan. The IV contrast helps us clearly see parenchymal injuries like lacerations or hematomas, as well as any vascular involvement. One key finding to look for is the contrast brush, which you can see in the image on this slide. It appears as a bright spot in or near the spring and indicates active bleeding. Finally, the CT scan allows us to assign an AAST injury grade, which is critical for deciding whether to manage the patient operatively or non-operatively. So AAST grades, grades 1 to 3 are considered low to moderate stability, and they're often managed non-operatively, especially in stable patients. Grade 1 injuries include small subcapsular hematoma involving less than 10% of the surface area or laceration less than 1 centimeter. Grade 2 involves moderate hematomas with lacerations 1 to 3 centimeter, but not involving major vessels. Grade 3 includes larger injuries, over 50% of the surface area affected, or lacerations deeper than 3 centimeter. Grades 4 and 5 represent severe splenic injuries, and these often require ICU care and surgical intervention. Grade 4 includes hiatal or segmental vessels injury, leading to significant devascularization, more than 25% of the spleen. It may also include a pseudoaneurysm or arteriovenous fistula. Grade 5 is the most severe. It describes either shattered spleen or complete hiatal devascularization, meaning the spleen has lost nearly all its blood supply. The FAST exam is a quick bedside ultrasound used to detect hemoperitoneum or free fluid in the abdomen. It's especially useful in unstable patients when CT is not immediately available, but we need to remember that its sensitivity is limited. In adults, it ranges from 83 to 91%, but in children, it drops to just 62%. So a negative FAST exam doesn't rule out splenic injury, especially in pediatric patients. If there is still clinical concern, CT scan should be considered. When splenic injury is suspected, the first step is immediate transfer to the hospital for further evaluation and management. And some patients may need ICU admission, especially if they have signs of hemodynamic compromise or contrast brush, grade 4 or 5 injuries on CT, or if they require blood transfusions. For patients who are stable, we usually admit them for observation. The general guideline is to observe them for grade +1 days. So for grade 2 injury, you would observe for 3 days. This helps ensure we catch any delayed complications. In general, non-operative management is preferred for patients who are hemodynamically stable. It has high success rate, 75 to 93% in children, and adults 35 to 65% in adults. One reason is that the pediatric spleen is more elastic and better able to tolerate trauma, even high-grade injuries. Another major reason to avoid surgery when possible is the risk of OPSI, overwhelming post-splenectomy infection. It's characterized by rapid progression of a bacterial infection, often causing severe sepsis and even death within 12 hours. Surgery is indicated in several situations. If the patient is unstable, if they fail observation, if they have a grade 4 or 5 injury with active breathing, or if they're a risk of pseudoaneurysm, which may require angiography for diagnosis and treatment. There is another option. Angiographic embolization is a minimally invasive technique used to control bleeding in splenic injuries. It's especially helpful for adults with high-grade injuries or when the contrast brush is seen on CT. It's also considered in patients who are at high risk for delayed hemorrhage, such as those with pseudoaneurysms. These pseudoaneurysms may from inside the spleen due to intraparenchymal hematomas that expand over time and can eventually rupture. This technique allows us to avoid surgery in select patients while still effectively controlling bleeding. Delayed splenic rupture is a rare but serious complication of non-operative management. It refers to a rupture that occurs 48 hours or more after the initial injury, sometimes even days to weeks later. It's reported to occur in about 1 to 8% of adults and up to 7.5% in children. This complication may result from expanding hematomas or pseudoaneurysms that rupture over time. Because of this, it highlights the importance of close follow-up and the cautious approach to return to play decisions, even if the patient initially appears stable. After splenectomy, patients need vaccination for the pneumococcus, H. influenza, and meningococcus. Revaccination with the pneumococcal vaccination should be considered after 5 years. Okay, return to play. There is currently no evidence-based standard for return to play after splenic injury. The time frame is highly variable, ranging from as short as 3 weeks to as long as 3 months, depending on the case. Ultimately, the decision depends on several factors: the severity of this injury, whether it was treated operatively or non-operatively, and how the patient is feeling, especially regarding pain and energy levels. In general, we take a cautious, stepwise approach, gradually increasing activity. When splenic injuries are managed non-operatively, the general recommendation is to limit the athlete to light activity for 3 months, regardless of the injury grade. After the 3 months period, if the patient remains asymptomatic, they can gradually return to full activity. When splenic injuries are managed operatively, most athletes need time to fully heal before returning to contact sports. But impressively, there have been cases of athletes returning as early as 3 weeks post-op. Ultimately, return to play decision must be individualized. We have to consider the type of sports, the athlete's position, and how well they are healing both clinically and functionally. Okay, let's talk about follow-up imaging after splenic injury. Routine follow-up CT scans are not usually needed unless the patient has persistent or unexplained symptoms. It's important to note that CT findings often lag behind physiologic healing, so a delayed image may not reflect actual recovery status. According to radiologic studies, 84% of patients show complete splenic healing on CT by 2 to 2.5 months, regardless of the initial injury grade. However, follow-up CT may be considered in patients with high-grade injuries, such as ASD grade 4 or 5, or if symptoms continue or worsen over time. Okay, to wrap up, here are the key points to remember. Always keep a high index of suspicion for splenic injury in any athlete with abdominal trauma, even if the mechanism seems minor. CT scan with contrast is the gold standard for diagnosis in stable patients. The majority of splenic injuries are managed non-operatively, especially in pediatric and stable adult patients. Athletes can typically begin light activity after 3 months, with a gradual return to full sports based on symptoms. Routine follow-up imaging is not necessary unless symptoms persist. Finally, close monitoring is essential throughout recovery and return to play planning to ensure a safe and complete return to activity. Thank you for listening.
All right, well, thank you, Dr. Hisatomi, for your presentation. Before moderating the question and answer, I'd like to give his club mentor, Dr. John Kiel, an opportunity to share additional comments about the article or topic.
Sure. Pardon my tardiness. That was a great lecture. Always a difficult subject. I was trying to find if there's any updated guidelines or papers, and it's really a dearth of literature, I think, on the subject. I will say, because I'm an ED attending, I see a lot of splenic ruptures that are, of course, in non-athletes. And I have a couple thoughts. One is, don't get burned by shoulder pain. I see curve sign probably once every 6 months in the ED. It's very common. It may not be splenic rupture, but something is diaphragmatic and referred. Two is you can have intracapsular bleeds. So you can have a splenic rupture and have a negative fast, but still have significant pathology. I realize we kind of talked about the sensitivity of it, but even among my EM residents, I think there's some confusion there. So the ultrasound, as much as we need it, and it is useful for a lot of things, unfortunately, splenic rupture ain't it. And usually when it is, they're already pretty sick, right? They already have hemoperitoneum. And then the third thing, probably the most challenging thing, I guess, for a sports med faculty is just like, when do you let these guys play again? And I think you sort of summarized that well. And the answer is there is no answer. And you're going to have to just use clinical gestalt combined with how the patient was managed, their level of competition, your level of risk that you're willing to assume, et cetera. But those are my thoughts. Great lecture.
And before we get to the question and answer, my experience, I also spend 50% of my time in the ER too as an ER physician. And I teach ATLS. And one thing we teach in ATLS that this article brought to light is that if the patient's stable hemodynamically, you can get a CT. If they're not hemodynamically stable, then you take them to the OR. And that's commonly a board question. They'll give you a presentation and they'll ask you, what's the next step? Or what's the next best step? And typically it's an unstable, splenic injury. And you want to straight to the ER, bypass the CT scan. Especially if you're transferring a patient and you don't have a surgeon and you're working in rural America. Shockingly to some people's surprise, you don't CT them at your facility, you transfer them, because by the time you CT them and then transfer them, they could be dead. So you transfer them straight to the OR. And another common board question is the FAST exam. And don't be fooled by the FAST exam. It doesn't technically diagnose a splenic injury. What you see with the FAST exam is you see fluid. And so it'll ask you that, which one do you see, a splenic injury or you see fluid? And the answer is fluid. You supposedly indirectly, same with the liver, same with the other body parts, indirectly suspect that there's an injury. And we did a journal club a few months ago where we talked about mononucleosis. And they keep lengthening the time from diagnosis to return to play. Some articles said 21 days, then 28 days. And I think the current recommendation is to wait 35 days if somebody has mono to prevent a splenic rupture. But overall, great lecture, nice slides, nice presentation. I don't see any questions on the board. Does anybody in the audience have any questions? I'm in Texas, and I did my training in Oklahoma, and rodeo is real popular here. So I've seen a lot of smashed spleens from bull riding. So bull riding is very, very common. And we do a trauma conference every year, and we did a rodeo themed one. And one of the surgeons did a presentation, and just amazing, all the smashed spleens. When a 5,000-pound bull falls on you, crushes your ribs and crushes your spleen. So a lot of splenectomies in Texas and Oklahoma.
Cool.
And so let me introduce the second presenter. I'm pleased to also introduce Dr. Nathan Katz. His club mentor is Dr. Jeremy Roberts. Dr. Katz is a PGY3 physical medicine rehab resident and current chief resident at Metro Health and Case Western Reserve University Physical Medicine and Rehab Residency Program. His interests in sports medicine include ultrasound of the musculoskeletal and neuromuscular diagnostics, percutaneous tenotomy, tennis medicine, running medicine, osteopathic manipulation medicine. His fun items to share: he enjoys playing competitive tennis in leagues and tournaments in Northeast Ohio. He also serves as an assistant coach with Baldwin Wallace University men's tennis team when time allows. As a medical student, I did spend some time in Ohio, both in Dayton and Columbus. And I can tell you, it gets a lot colder there than it does in Texas. His presentation is on the article Evaluation in Elbow Pain in Adults. And of course, I'd like to thank Dr. Jeremy Roberts for serving as his club mentor. Dr. Roberts is also a sports medicine fellow at Atlantic Sports Health Morrison Medical Center. Prior to sports medicine, he trained in PMNR in New York Presbyterian Hospital, subsequently trained in a pediatric rehab fellowship at Children's Hospital in Colorado. Sports medicine interests include concussion management, sign-line coverage of all types, and ultrasound-guided pictures. And his fun fact is he can recite all of Shrek. I'd like to turn it over to Dr. Katz to make his presentation.
Thank you. Thank you. I want to just confirm you guys are seeing the right stuff. You guys seeing the slides without the presenter mode?
Yes.
Perfect. Okay. All right. Score a 1 win for us Mac users. I was able to make it work this time around too. So good. So thank you for that great introduction. Want to again thank Dr. Roberts especially for his advisement on this presentation. We'll be going over the evaluation of elbow pain in the adult, an article by Dr. Kane and colleagues out of North Carolina. And then also want to say, like, unlike many other journal clubs, the format of this presentation, especially in this article, is largely based on evaluating the clinical presentations and diagnostic evaluation that helps to inform the differential diagnosis of elbow pain, specifically regarding region. And we'll have a few things for you guys to put in the chat that I'll be able to monitor from my screens here. So we'll try to get y'all a little bit engaged in some differential diagnosing. So before looking at our elbow pathology, it's important to refamiliarize yourself with the foundational anatomy that influences the elbow. For the purposes of this presentation, I'll have the slides here to reference, but we'll not discuss these in depth. And to start, here are the various joints that make up the elbow. Next, we have the ligaments and capsular structures. And the muscles that are responsible for the core motions of the elbow, such as flexion, extension, pronation, supination, along with other motions. It's important to understand the fundamental initial components of any elbow evaluation, which includes inspection, palpation, range of motion assessment, along with strength testing. Next, we must understand our core imaging and diagnostic tools to help us in diagnosis. Plain radiography is the initial choice for the evaluation of acute injuries. In chronic conditions, this can also be helpful for evaluation of enthesopathy, bone spurs, and osteochondral diseases. And then musculoskeletal ultrasound, which is massively growing in scope for our specific specialty of interest here in sports medicine presenting here. It allows for inexpensive dynamic evaluation of commonly injured structures everywhere across the body, but particularly in the elbow here. And then we also have MRI, which the article, especially like, and I'll lean on Dr. Roberts eventually to help us out, along with yourself, Dr. Troxler, to kind of add more flavor, because this is an article that's a little bit dated, about going back to 2015, still has fantastic value in us practicing resident physician fellows and practicing attending sports medicine physicians. And the article states that magnetic resonance imaging is a preferred imaging modality for chronic elbow pain, but would like to give the caveat that there are other clinical uses for MRI beyond this that I won't go as much in depth on, but would say that this is a great modality for identification of ligament tears, osteochondral defects, along with loose bodies potentially. Looking specifically at our two soft tissue imaging modalities, ultrasound and MRI, to consider one versus the other. Ultrasonography, for instance, is more operator dependent than MRI, which is a con against it, although that's why you go through a big sports medicine fellowship practice here to kind of develop an expertise in this imaging modality. Ultrasonography is less expensive though than MRI. And then comparing the diagnostic applicability of it, there's a variety of sensitivity and specificity for a multitude of elbow-based pathologies, some of which we'll talk about tonight. But the one I'd like to kind of leave you with data-wise is sensitivity 64 to 82% for the diagnosis of medial and lateral epicondyle tendinopathy, compared to the sensitivity of 90 to 100% with MRI. So a couple differences there in terms of accuracy of your diagnosis, but also the ease of usage in ultrasound. All these things factor in. Next, we have our other modalities for diagnosis, such as electrodiagnostic studies that are helpful in the diagnosis of peripheral compressive neuropathies, but can also help us in evaluating for other differential diagnoses items like plexopathies and cervical radiculopathies. Another imaging modality I wanted to mention that isn't explicitly mentioned in the article, but something to consider is arthrography. It's an option for detailed evaluation of intra-articular pathologies and potential ligamentous injuries, especially in the cases where the initial x-rays are a little bit inconclusive. All right, so now for kind of the group presentation, I'll be able to see you guys in the chat posting and stuff. If we think about the regions of the elbow, let's start with the anterior elbow. You got a patient coming in, anterior elbow pain. What are some differential diagnoses that come to your all's minds? And I'll give you guys a couple seconds to throw a few things in the chat there. And then no wrong answers here, 100%. Like it's all about just kind of getting the brain started, getting you thinking about the differential diagnoses that pop in your mind. Thank you, Jason. Thank you, Eric. Thank you, Ryan. Awesome. So already getting some good responses. Got even more coming in. I'll kind of play a little bit of a spoiler for any one of y'all who have had a few guesses kind of waiting in there, but the article points out a few especially. Let's see here. Is it gonna let me? Perfect. Okay. So the article points out a couple different anterior options here. Distal bicep tendinopathy, intra-articular pathology such as osteoarthritis, rheumatoid arthritis, gout, anterior capsular strain, and pronator syndrome are just some of the few that come up for anterior elbow pain, even though this is not a comprehensive list. The one pathology let's go over specifically in the anterior elbow is distal biceps tendinopathy. It presents with insidious onset of anterior elbow pain, prominent with resisted flexion and supination. And the history may demonstrate exactly that. It might demonstrate repeated elbow flexion with supination components. And then you have particular concern for biceps tendon tear, because on the tendinopathy spectrum, you do have tearing on that tail end of that spectrum. You get concerned for this when that normal piston-like movement of the tendon with action is absent. And then you also have particular physical examination maneuver, that hook test, which is a test which involves the examiner hooking the biceps tendon with his or her fingertip. That'll confirm an intact tendon and may even assist in localizing a pain generator. Next up, let's run it back for the medial elbow pain now. So patient coming with medial elbow. What are y'all thinking in terms of a differential diagnosis item? Let me give you guys a few seconds to throw those in. Thank you, Jason. Thank you, Milan. Awesome. Perfect. Jason, throwing in double. You're going to go for extra credit today. Awesome. And thank you, ID, if I'm pronouncing that right, and Dr. Hisatomi, thank you. All right. So a couple of the ones that the article points out, especially here, are medial epicondyle tendinopathy that a bunch of y'all hit on, cubital tunnel syndrome, ulnar collateral ligament injury, and that valgus extension overload syndrome, all as potential options for medial epicondyle differential diagnosis items. So looking at a few here in this medial portion of the elbow, medial epicondyle tendinopathy tends to come to folks' minds. The history involves repetitive tasks that involve valgus stress, elbow flexion, wrist flexion, some pronation as well. It'll include insidious onset of pain localized to slightly distal to that medial epicondyle. And will often involve resisted pronation and wrist flexion, likely eliciting pain. And you'll kind of lean on that with your multiple various physical examination maneuvers for this area. And then with the diagram to the right, you'll see a multitude of different musculatures that kind of contribute to the tendinous structures that insert here. Next, let's zoom in on the ulnar collateral ligament. This is commonly injured in overhead athletes, results in a valgus elbow instability picture. And then it is important to know that it's an acute injury that tends to occur with a pop type sensation and also develops pain and bruising to that same area consistent with the ulnar collateral ligament. You'll also find tenderness along the area, along with a high degree of sensitivity is that tenderness where that ligament is. A couple different physical exam maneuvers that I wanted to familiarize y'all with, and you see diagrams here above with it. The first is the moving dynamic valgus stress test. It's got pretty good data behind it, 100% sensitivity and 75% specificity for UCL injury. Test is performed with the shoulder at 90 degrees of abduction and external rotation. And then while maintaining a constant valgus torque on the elbow is quickly flexed and extended, with a positive result detailing pain specifically between 70 and to 100 degrees of range of motion of flexion, along with a few of the other characteristics such as instability apprehension potentially in there as well. And then there's a milking maneuver, which differentiating between the two, you can tell the milking kind of more from him grabbing the thumb in the picture here. Perform with the forearm supinated, shoulder abducted, elbow flexed beyond 90 degrees. The examiner then pulls the patient's thumb posteriorly, creating the valgus force in this case. And then this one, similar kind of findings. If pain, instability, and apprehension are recreated, then you're feeling more comfortable with the UCL being a component of the injury here. And then it's important to note that if an ulnar collateral ligament injury is suspected, the medial joint space of the symptomatic elbow should be compared to the asymptomatic side for the amount of opening, the subjective quality of the endpoint, while that valgus force is being stressed across that joint, along with the degree of pain. Okay, next up, we got cubital tunnel syndrome on this side. This is a compressive neuropathy of the ulnar nerve at the level of the cubital tunnel. It develops paresthesia at the ulnar forearm and hand going into the fourth and fifth digits. Often concomitant with medial epicondyle tendinopathy is an important component here because these patients might present with that medial epicondyle pain or medial sided elbow pain rather. And then you have to kind of differentiate out these things, but don't be surprised if things are existing concomitantly. And the sequelae of this condition, if not treated properly and promptly, is weakness of the hand intrinsic musculature, especially. Physical examination wise, you'll get some positive tenales at the cubital tunnel, palpation of the cubital tunnel upon flexion extension may even demonstrate subluxation, which is a consideration here. And it's important to note with these kind of neurologic-based presentations, you have to consider physical examination of the whole upper extremity along with the cervical spine to help with kind of broadening out your differential and ruling out other potential confounders here. And then got another challenge question for you all here. So what is on your differential diagnosis for a patient presenting with this hand in a rested position with the picture demonstrated here, what the hand is looking like? Take a second to kind of absorb and then go and throw in a couple differential diagnoses that are coming to your mind here in terms of what's going on with this patient with this resting hand position. And we'll give you guys a couple seconds here. I love that one, Dr. Troxler. Yeah, got a couple of these coming in. Thank you, Jason. Thank you, Milan. Perfect. All right, already getting a lot of good question or good differential diagnosis item rather. So let's go ahead and figure out with this one. This image does demonstrate a claw hand. I think I saw someone put in the chat. Likely indicates an ulnar nerve injury. A key component of this presentation is that this hand is in a resting position, right? You're not having them flex to make a fist. And because of this, we're concerned for that ulnar nerve injury as a sequelae of a potential cubital tunnel and what have you. But really, the differential diagnosis is vast here. You're looking for anything that's going to implicate the ulnar nerve at this point in the hand, right? So cubital tunnel is an option here. More distal nerve injury affecting the ulnar nerve, such as an acute fracture at the wrist, a compressive neuropathy at the wrist, are considerations with also your lower trunk brachioplexopathy. I saw the Klumpke palsy in there. Cervical radiculopathy in theory could consider this presentation as well, even though it'd be a little bit more of a stretch. So a lot of different differential items to consider here. All right, now keeping you guys busy. I said I would, and we're doing it. So lateral elbow pain, what are y'all's differential diagnoses items here? Like I said, no wrong answers. You can fire them off. There's probably a few common ones banging around all our minds. And then the few other ones we got to think about. Perfect. Yep. Plenty of the ones. The one that's keep coming to mind are tennis elbow, lateral epicondyle tendinopathy. So that's the one the article points out, right? First and foremost. Other ones on there are the osteochondral defects that can happen here. Plica, posterior lateral rotatory instability, radial tunnel syndrome, posterior osseous nerve syndrome. I even see a radial head subluxation component to here, right? So with a patient with more of a acute presentation, got to think about that. And this article does a really good job giving out that evaluation of the elbow pain, but not a comprehensive list here, right? So things like those acute injuries like the radial head subluxations, you got to consider. All right, everyone's talking about lateral epicondyle tendinopathy, tennis elbow, so let's talk about it. Lateral epicondyle is the origin for the common extensor tendon. The etiology linked with this tendinopathy is with repetitive occupational or recreational activity. Maximal tenderness for the patient will be approximately 1 centimeter distal to the epicondyle at the origin of one of the more commonly implicated tendinous structures here, the extensor carpi radialis brevis. But as you can see in the diagram, there's a multitude of the extensor musculatures that contribute to this tendon. Pain and decreased strength with resisted gripping and with wrist supination and extension are often present on your presentation here. This can be a whole separate sports med topic by itself. So let's go into kind of another pathology here. And this is a bit one of my busier slides, unfortunately, but I think it's an important one where we talked about radial tunnel. Another one I want you guys to think about is posterior interosseous nervous syndrome. And these two are super commonly kind of confused with each other. And the article tries to do its best to kind of separate these two out. So I'm going to try and do that here as well. So radial tunnel syndrome, radial nerves involved. That's a more proximal portion of it before it does any of its splitting into its major branches. The primary symptom is pain, especially with this presentation, dull and aching in that proximal portion of the forearm. The pain location is pretty unique here, where it's 3 to 5 centimeters distal to your lateral epicondyle, where for that lateral elbow region, if you feel like it's farther down in the forearm, then you're feeling like it's your standard lateral epicondyle tendinopathy, then some to consider. Not really a ton of motor deficits here. If they are, they're minimal. And there's more of a fatigue-like symptom component with it here, which can occasionally confuse you for that neurologic symptoms and broaden your differential. Not as much of the sensory nerve deficits here. The causes of the compression here are kind of vast, but you think about your fibrous bands, vascular structures, hypertrophied muscles near that radial tunnel especially. Some provocative tests can be pain with resisted middle finger extension or resisted supination, but it's not so much weakness there. And then again, always going to be our differential here is your lateral epicondyle tendinopathy. And then posterior osseous nerve syndrome, commonly confused again with radial tunnel syndrome. You're getting the deep motor branch of the radial nerve, motor weakness without pain sometimes, but if there is pain, there's might be minimal weakness of wrist and finger extension. You can also have thumb extension weakness. There can be compression at the arcade of Frosch or deep within the supinator musculature, and you're really going to lean on your nerve conduction studies to tease out the degree of weakness going on here in the prognostication and diagnostic component here. And you want to think about tendon and cervical radiculopathy rather in your differential here. Quick challenge question for y'all again. Patient presents with right-handed weakness. Evaluation demonstrates an unorthogonal sensory examination in regard to peripheral nerves and dermatomal distribution, but there is marked weakness of finger extension. Which of the following muscles is not implicated in your suspected diagnosis? So a little bit of a second order question for y'all to keep you on your toes. So 1, 2, 3, or 4, give me your best guess or give me your best answer, whatever y'all got for me. Got plenty of takers for 2 so far. Anyone want to stand out, go for 1, 3, or 4? Mostly people are sticking with 2. Okay. All right. So with this one, we are looking at number 2 here as our correct answer. So brachioradialis is the only muscle that does not get its innervation from that distal branch of the radial nerve, aka the posterior interosseous nerve, while the others here are all supplied by that posterior interosseous nerve. And while there are several items on the differential here for this patient presentation, because it's still a little bit lacking in terms of how much you'd want to develop in terms of the HPI, the examination here, that marked weakness in finger extension really points you toward that PIN as an option here. All right. And last but not least, differential diagnoses for posterior elbow pain. And then I'll stop bugging you guys for all these chat items. So what's on your differential for that patient kind of grabbing at their posterior elbow, feeling a good amount of pain in that region? What are y'all thinking that comes to mind? Awesome. We got Milan Mark putting it in there, Jason there too. Excellent. And just for the sake of time, let's jump into it, right? So with the article, they point out a few here. They talk about olecranon bursitis, exactly like Mark was saying. You got your olecranon stress fracture, which is also a consideration here. Posterior impingement can also be prevalent. Triceps tendinopathy, along with any good old-fashioned osteoarthritis, depending on what the flavor of joint involvement is. All right, so let's talk about olecranon bursitis, especially here. So you can have a septic or aseptic variant. The septic variant tends to present with pain, swelling, warmth, and erythema over the olecranon. Can be diagnosed-wise, can be confirmed by bursal fluid analysis, but this isn't always necessary. You have an aseptic variant that has a history of minor trauma to the elbow and a boggy, non-tender mass over the olecranon without those signs we see in the septic variant, right? Without those redness, warmth, other signs of infection that we look for. And then consideration for aspiration of this one, especially if you're concerned for an aseptic variant, is only when the diagnosis is uncertain or for symptomatic relief in refractory cases. Again, this article is a little bit dated in that way, so I'll lean on our colleagues here, the fellows and attendings on the call to kind of add a little more clinical gestalt here, but this is just something the article puts forth, especially as a consideration. All right, and I'm wrapping up here on time here. So let's wrap up with what the article recommends in terms of the clinical recommendations to really put forth in your practice, or to at least start the conversation and think about what to add to your practice here. So the article first states that magnetic resonance imaging, as I discussed prior, is a preferred imaging modality for chronic elbow pain. However, big caveat here, right? Because there's other clinical uses for the MRI beyond this. You also pointed out that the article also points out that if there's an ulnar collateral ligament injury suspected, the medial joint space of the symptomatic elbow should be compared to that asymptomatic side for the amount of opening, the subjective quality of the endpoint, along with pain. But again, there's nuances here, and there's growing evidence for things like ultrasound, MRI, all these type of modalities, and further diagnosis here to expand and supplement your physical examination. Other clinical recommendations I recommend are in patients with signs of compressive ulnar neuropathy of the cubital tunnel, a physical examination of the upper extremities at large, cervical spine are both essential to rule out other compressive neuropathies to kind of round out your differential. And then one thing the article points out specifically, to avoid introducing infection, right? We're always tasked with the option to do no harm in our patient cases, right? So to avoid introducing an infection, aspiration olecranon bursitis that they recall and mention is performed only when that diagnosis is uncertain or to help relieve symptoms in refractory cases, specifically in that aseptic variant of olecranon bursitis. I want to thank you all for your time, getting out of the Cleveland, Ohio area, and want to cede the rest of my time to Dr. Roberts, Dr. Troxler for helping add a little more relevance and a little more up-to-date components to this journal article.
All right, well, thank you, Dr. Katz, for your presentation. Before moderating a question and answer, I'd like to give his club mentor, Dr. Jeremy Roberts, an opportunity to share additional comments about the article or topic. Dr. Roberts.
Hey, so great job, Dr. Katz. That was fantastic and very engaging. And people spend a year long doing an elbow fellowship in and of itself. So to go through 20 minutes isn't easy, but I think we got a lot of the highlights, and especially regionally based. A couple things that, especially given this article is from 2014, 11 years later, I think at AMSSM, there's a nice presentation on ultrasound of the UCL, and for those who are more advanced and willing to do so, being able to detect any laxity or any increase in space of the joint after ultrasounding the UCL, I think can be valuable for those who have it in their practice as opposed to relying just on exam. Another thing, I know you mentioned it a couple times, but using the MRI in the acute settings, not just chronic settings. I think on an update of the article, I think they would talk about that more. If you're concerned for a very acute tendon tear, or we see the story very often of a parent catching a football from their child that was thrown, and then they catch it and then they feel a pop rather suddenly, or with carrying a heavy water bottle case, and all of a sudden they feel a pop or a strain, that could be a case, especially if you're in close contact with your orthopedic surgeon, that you might just go to an acute MRI if you're thinking that this patient may be an orthopedic candidate. Something the article didn't go much into was a lot of bony injuries of the elbow, including fractures and such. Obviously, we don't have time to go more in depth, but I think a key thing and something the boards like to emphasize, especially for radial head fractures, is concern of if it's pain that's limiting range of motion versus the fracture itself. So anesthetizing the area and seeing that there's a mechanical block or not can be very helpful to know if you might need more advanced intervention versus just pain control for any radial head fractures. And then the last thing I wanted to mention is, again, this article goes very brief into lateral epicondylosis. I think one thing that I've added to my practice this year that I hadn't really thought of is using like a chair test to assess for pain in lateral epicondylosis, having them reach out in front of them and trying to grab a chair, the top of the chair like this. And if the other tests are Mills, Monthly, and Cozen's are negative, this can very easily, especially with the elbow extended, they'll have pain pretty much right away, and that kind of solidifies the diagnosis for me. And then something they didn't really go much into is using steroids versus not steroids. I know our orthopedic colleagues are probably a little more liberal in their use of steroids to this tendon than we are, but a lot of the evidence shows that after 6 weeks, there's really not much difference in outcomes on steroid versus non-steroid. But again, that's a whole other article. In fact, there's a plethora of meta-analyses and articles on that subject.
Before we, let's see, find my, looks like my, there we go. My mouse died. Just a couple of comments before we go to question and answers. And probably some of the most difficult things about sports medicine is some of the body structures have similar names. So in the elbow, there's a UCL, but also in the thumb, there's a UCL. So try not to confuse those. Also, when we talk about tunnels, there's bony tunnels and there's musculofascial tunnels. So like the radial tunnel is more of a muscle fascia tunnel, whereas the cubital and the some of the other tunnels are more bony. One thing the articles did talk about EMG nerve conductions. You can get a false negative test if you do it too early. And so it says to wait 6 weeks to do those tests, maybe 4 weeks. And something that's always surprised me is the sensitivity and the specificity of these exam findings. We did a ACL tear a few months ago, and like the anterior drawer test, you will only catch, if you have 100 ACL tears, you'll only catch 60, you'll miss 40. And so just remember, especially for ACL and some of these other body parts, that if you have a negative exam, doesn't mean it's not torn or it's not injured. You may still need an MRI. A lot of big things on the boards is they like to distinguish between osteochondrosis versus osteochondritis. Just to know, osteochondrosis is before puberty. There's usually not any free-flowing or separate parts. There's always exceptions. Osteochondritis is usually there's separation from the bone. Of course, you can have separation from the bone in osteochondrosis, but not usually. And so if you can remember those two things, that'll really help you learn the osteochondritis dissecans versus osteochondrosis. And they talk a little bit about that. One thing it didn't talk about, it talked about posterior osseous syndrome. There's also an anterior interosseous syndrome. And so anterior interosseous syndrome, it's a median nerve, and you get weakness and not so much sensory. The weakness is the flexor pollicis longus, flexor digitorum profundus. And so your patient can't do this, so they can't hold it. And so you'll be able to pull it apart. So if they can hold it, then it's not the anterior interosseous. If they can't hold it, then it's anterior interosseous syndrome. And they did talk about MRI arthrogram, and try not to confuse that with MRA. So MRA is a angiogram, that's the vessels, and MRI arthrogram is different. And so this is really becomes prevalent. I had a patient with shoulder pain, a football player. We MRI'd him, and he was still in excruciating pain. And we said, "Whoa, what's this? What's going on with this guy? He just doesn't want to play." And we said, "Oh, he may have a labral tear." So we did the MR arthrogram, and sure, the regular MRI missed the labral tear. You really need to do the MRI arthrogram to really pick some of these things up. And so you really have to know the limitation of your tests. And so great job. I like the question and answer format. My recommendation maybe in the future meetings as we pick that up. I like the engagement and you know, getting people involved as much as we can and make it an exciting presentation. Of course, I'd like to thank our two presenters. Let me see, did we have any questions in the question?
I saw one there that I'd like to take the first crack at. I'm not sure if you're a OMM enthusiast, Dr. Troxler, but I do a ton of it in my kind of early practice and hope to do a ton of it as an attending here in the future. So I'd like to take a crack at Milan's question here.
So shoot at it.
So any common OMM techniques you've used for elbow pain? I always like to specify, I guess, let me kind of I've seen more lateral epicondyle tendinopathy in my early career thus far. So I've tried to adapt a lot of OMT techniques to that pathology to answer your question best. With the other elbow pathologies, I just haven't seen enough to give you a really concrete anecdotal based evaluation to kind of how I approach and add OMT to the clinical practice yet. Hope to eventually have a more comprehensive answer for you there. For lateral epicondyle tendinopathy, in instance though, I look for somatic dysfunction around the adjacent area, of course. If you're treating your radial head somatic dysfunction, even if it's not overt subluxation and more of our MD colleagues and, what we're looking for acutely with kind of our workup, right? You can have subtle somatic dysfunction and subtle movements and asymmetry from side to side that if you're able to treat that with a muscle energy-based technique, for y'all who are familiar with some of the osteopathic techniques out there, can be a beneficial one for just improving movement. The tolerance can sometimes be really challenging because elbows can be really painful buggards, unfortunately. So they might not have as much tolerance for muscle energy. Then you can adapt that into a strain counter strain kind of positioning with a couple different techniques out there referenced across the various osteopathic manuals out there. I like to really use a whole kinetic chain approach, whether I'm using osteopathic kind of philosophy and mindset or as a sports medicine doctor in the future. So I'd look at the scapular motion, especially because that's what our physical therapy colleagues are working on when we're sending them for physical therapy for this condition. We're working on improving scapular mobility. So if I can address some of those myofascial based restrictions to motion in the shoulder by whether it's doing scapular based mobilization, figure eight, Spencer techniques, or kind of more mobility based motion of the glenohumeral joint, all those things that kind of translate to better motion at the elbow. And we can get that patient moving even a little bit more fluidly throughout their kinetic chain by just helping out with OMT. That's a lot of time is my go-to kind of mindset and philosophy when I'm looking at adding OMT to a treatment of like a lateral epicondyle tendinopathy or even a medial epicondyle tendinopathy. Does that kind of address some of your question, Milan? Awesome.
And, we push, in therapy, we push a lot of eccentric therapy versus concentric. And I always felt like OMT was more related to a eccentric contraction. And I think that's why scientifically, that's probably why OMT works and why I've had success with it, especially with tendinopathies. You can lengthen and contract that tendon at the same time. It seems like it gets better faster. It's just one, modality that we can add to our toolbox and kind of go from there. Let's see. So looks like we got all the questions. Of course, I'd like to thank our two presenters, Dr. Hisatomi and Dr. Katz, for outstanding presentations. Also like to thank our two club mentors. Dr. Kiel and Dr. Roberts. I'd also like to thank everyone for attending tonight's AMS Journal Club. It's also my pleasure to serve as club advisor moderator for tonight's meeting. And of course, I'm always pleased to announce that we have 2 upcoming AMSSM Journal Clubs in May. Our next Journal Club will be this Thursday, May 15th at 8 o'clock Eastern Time, 7 o'clock Central Time. And then we have a 3rd Journal Club meeting on Tuesday, May 20th at 8 p.m. Eastern Time. And we also have a book club for those interested. In the book clubs, we do different sports. So we've done track and field, we've done soccer, we've done cricket. Last time, let's see what we do. I think last time, can't remember, but volleyball. We did volleyball previously. At the end of the month, we'll be doing a book club. The book is called Legacy, and it's about the New Zealand rugby team for those rugby fans. The New Zealand rugby team, they wear black tops and black bottoms, so they're called the All Blacks is their nickname. And it's a really good book about leadership and teamwork. It's on it. Of course, you can get it from Amazon. I couldn't find it in my library. The New Zealand team is the all-time most winningest team ever in any sport in the world. And so if you go to YouTube and type in the New Zealand rugby team, they do a 30 to 60-second chant before each match, and the other team faces them, and kind of a chant to try and psych them out. And the other team just kind of stares at them, and it's pretty good. And so this is a kind of an unexpected book success. The guy that was writing it was just his love for rugby, not so much as a leadership book, but it's been a bestseller in many different fields. I hope you can join that others. You don't have to do a presentation. We always want you to join us at our meeting, and this is the conclusion of tonight's meeting. Thank you all for coming.
Thank you.
Thank y'all. Have a good night. Okay.
Have a good night, everybody.